All right. Good evening, guys. Good evening. Can you all see me? Can you all hear me? Okay. Hi, guys. Good evening. Good evening. Can you all see me? Can you all hear me? All right. Great. Thank you, Zuko. Good evening, Voids. ANG Void. Somebody. All right. Okay. I hope everybody is fine. Acha, I've been getting a lot of requests on my personal Instagram account as well as on the PW or बैकहैंड टीम कि भाई BLS वीडियो में सर थोड़े हिंदी में पढ़ाइए. I don't know if how many of you are comfortable in Hindi per se. We can use a little bit of Hindi here and there, but for a wider audience यार अब इतना इतना भी you should not become selfish ना कि हम सिर्फ अपना अपना देखेंगे भाई. Let's everybody get benefited. No, अब इतनी एफर्ट डल रही है, क्या बोलते हो? How many of you help in that नीसा हिंदी में ही पढ़ाओ? Anything of that sort? ऐसा कुछ है क्या? Quick feedback. Do I have the freedom to teach in whatever language I want to? English is fine. Okay. Okay, I'll try to what I'll do is I will use both the languages. Every single sentence that we use, I'll be using in English as well as a little bit of Hindi as well. Okay, so that both the set of audience remains happy. So, what is the topic for today? Today we'll be talking about a very small topic but very important that you'll see on an emergency basis, and that is what we call it as the corrosive injury. That is, you have the corrosive injury. Okay, so when you talk about the corrosive injuries, I hope most of you understand that this is basically an ingestion of an acid or alkali. Okay, so the basic objective that we were talking about, it is of ingestion. It is ingestion of acid or alkali. Now, I'm not going to say that it is going to be an accidental ingestion. Basic objective ये है कि किसी ने decide किया कि भाई suicide कर लेते हैं, तो suicide करने के चक्कर में acid या alkali पी ली. ठीक है? First of all those people who should get this, that you will not die because of drinking acid and alkali, but yes, your life will get difficult and difficult and difficult as it moves forward, and you will provide for a lot of doctors to get some benefit out of you, because obviously with all these problems, when you come down, you need to get treated and you will become a chronic patient. Okay, so please do not become a chronic patient. I would recommend strongly, this is not a good way to die. Okay, now usually, when you are in the casualty, there are two set of patients who are going to come. The set number one, accidental ingestion. This is common in children. Okay, so when you talk about the acid and alkalis, normally when you talk about a child who is unaware, and it so happens that you store these alkalis or acids at house in our, let's say, a water disposed bottle, किसी बिस्लरी की बॉटल में स्टोर कर लिया, किसी प्लास्टिक की बोतल में स्टोर कर लिया और पता ही नहीं चला. अब बच्चा चाहे 2 साल का हो, 4 साल का हो, 10 साल का हो, के मानो खेल के आया, कूद कूद के, he's thirsty, sees something which is transparent, looks like water, gar डाल दिया. Now here is a very important thing. So when when a patient is going to ingest, the quantity with which it ingest matters a lot. ठीक है? तो अगर acid और alkali का ingestion है, would you like to tell me that which could be a larger quantity a patient would ingest without knowing? Is it an acid or an alkali? Again, a very, very important concept to know. ठीक है? So when it comes down to this, what can a patient probably ingest more? It all comes with a very simple concept. The acid will have a very strong pungent smell. ठीक है? It is going to have very strong pungent smell, and it is going to be very I would say the taste is also going to be quite bitter in that context. Okay, so the minute the patient takes, the taste is bad, the smell is pungent, so you'll throw it off. Alkali, on the other hand, is less tasteful and it does not have that strong odor, so hence the large quantity of ingestions occur by alkali. It is not by the acid per se. So the basic concept when it moves down to, when you're looking at this whole scenario, I can have a patient who can have an ingestion of an acid or an alkali. तो पेशेंट गलती से चाहे वो एसिड पी ले या फिर वो अल्कली पी ले, लेकिन सवाल ये है कि इन दोनों में से ज़्यादा क्या पिएगा. लेट्स से अगर पता नहीं है और गड़गड़ पीना शुरू कर दिया, तो इन दोनों में से व्हाट डू यू थिंक इज गोइंग टू ड्रिंक मोर? ऑब्वियसली वो अल्कली ज़्यादा पिएगा व्हेन कंपेयर टू एसिड. ठीक है. In that context, when you have a patient who is not in differentiation between alkali as well as acid, so when I say acid, it is going to have a strong odor, it is going to have a bitter taste, whereas alkali on the other hand is going to be an odorless, and this is usually tasteless. So taking this into consideration, the consumption of acid is usually in low quantity. It is going to be causing a low quantity. It will have a low quantity consumption. Whereas alkali when ingested can have a large quantity ingestion. Can have a large quantity consumption. Okay. So when you have these two as the different component, Neil Kumar Soma. Okay, so guys, you can interact with each other. I don't have a problem. Take care of it. Okay. So when a patient is going to ingest an acid or alkali, acid strong odor का होता है, bitter taste है, so obviously less quantity will be taken into consumption, whereas alkali will be odorless, tasteless. There's a large quantity of consumption. Now, when you look at, see, obviously the damage or the extent of damage also depends upon the quantity of which the patient is going to consume. Now, when you talk about the acid, no, let's understand what is going to happen. Now, if you take this as the representation of the muscular layer that is present, above the muscular layer, we have our submucosa, and above the level of mucosa, submucosa, you have the mucosal surface, right? So let's say this happens to be the mucosal surface. This happens to be your submucosa, and then after the submucosa, you have the muscular layer. After the submucosa, you have the muscular layer, and this is the component that you have. Okay. So from outer to inner, you have the mucosa, which is the innermost layer. Then you have the submucosa, and then you have the muscular layer. Obviously, you have the inner circular muscle and the outer longitudinal muscle. The inner circular muscle and the outer longitudinal muscle, right? So for the sake of understanding, we'll replicate the same here as well. Okay. Now, when an acid is going to fall, let's say patient accidentally consumed an acid. When the acid falls, now the acid is going to cause injury to this area. Now, the minute the injury is going to occur at this area, this is going to result in development of a fibrotic scar, and that fibrotic scar is what we call it as eschar. So wherever the acid is going to fall, it is now going to develop, or it will create a scar-like presentation, which is called as an eschar. It's a fibrotic scar. It will not allow the acid to go into deeper tissue. So whatever damage is going to occur from the acid will usually remain superficial. तो लगता है कि एसिड से ज्यादा डैमेज होगा, लेकिन होता नहीं है. क्यों? एसिड जब वो म्यूकोजा पे गिरता है तो एक फाइब्रोटिक स्कार बनाता है, उसको बोलते हैं एस्कार. और ये जो फाइब्रोटिक एलिमेंटल और द फाइब्रोटिक कंपोनेंट ऑफ द स्कार दैट इज प्रेजेंट, this won't allow the acid to go into deeper tissues, so hence it restricts the damage. On the other hand, when the alkali is going to come and fall, on the other hand, when the alkali is going to come and fall, so we'll use a different color to depict our alkali. तो मान लो कि अगर alkali आके गिर रहा है, क्या कलर यूज करेंगे alkali के लिए? we'll use this color. ठीक है. Okay. Let's say the alkali, when it is going to come and fall on this, now the alkali is going to be causing a liquefactor necrosis. So वो धीरे धीरे करके ना, it is now going to go. So it is going to be like a water. It will continue to flow and then it will cause a transmural injury and causing perforation. ठीक है? Yeah. So the difference between an acid and alkali is when the acid falls, it will cause something called as coagulative necrosis. But when the alkali is going to fall, it will result in liquefactive necrosis. And because of this, in an alkali, there is a transmural injury from the mucosa all the way to the muscular layer. The entire extent is going to get injured. So obviously the extent of injury is more when compared to acid. Okay? So if I have to summarize in the same context, right? With respect to acid and with respect to alkali. Okay. Now acid ingestion, it is associated with coagulative necrosis. It is associated with coagulative necrosis. On the other hand, alkali is associated with liquefactive necrosis. This is associated with the liquefactive necrosis. It is going to be associated liquefactive necrosis. In the acid, you will see there is coagulation of protein. There is coagulation of protein, whereas in alkali, there is saponification of tissue. There is saponification. There is saponification of tissue. That is basically tissue melts, right? Saponification basically means it is going to dissolve. So tissue is going to dissolve in an alkali that is going to present, right? Now, as you can see, it is going to cause surface injury. Acid actually causes the surface injury, whereas this is going to cause deeper injuries. This is going to result in deeper injury, or I would say that it is going to cause more damage, right? It's going to cause a transmural, the entire thickness. The transmural injury is going to happen. It will result in a transmural injury, right? So here you have a patient with acid is going to have coagulative necrosis. There is coagulation of proteins. There will be surface injury and there will be presence of that fibrotic elemental scar that we spoke about, that is eschar. Eschar is not formed. I can say there is a transmural injury in the alkali that is going to occur. That is going to occur, right? Now, as the patient consumes this, okay, accidental, non-accidental, whatever might be the story, okay, चाहे लेफ्ट से हो या राइट से हो, कैसे भी हो, होना इंपॉर्टेंट है. अगर हो गया फिर क्या प्रॉब्लम है? लेट्स से इफ अ पेशेंट हैज कंज्यूम्ड एन एसिड और एन अल्कली, if the patient is consuming acid and alkali, it is going to cause some amount of injury that is going to happen. ठीक है? So to understand this, we'll take this representation of the stomach. Let's say this is the esophagus. So rather than saying the esophagus, when you talk about this is the orientation of the patient. ठीक है? So let's say this is the orientation of the patient that is going to present. Let's say this happens to be the neck region. Let's say this happens to be the thorax. And let's say this happens to be the abdomen, right? So this is what we are going to look across here. Again, I don't want to draw it twice. You all know it. So we will replicate it here. So when you look at in both the context, okay. So this is going to be the oral cavity. This is going to be present. This is the oral cavity, which is going to continue across here. This is going into the cricopharyngeal junction. From there, it is going to continue into esophagus. It is going to pierce the diaphragm at this particular level. This is going to pierce the diaphragm. I hope everybody knows that esophagus pierces the diaphragm at the level of T10. And once it pierces, it continues into stomach, and this is how it is going to go. Same thing is going to be here. This is going to be the oral cavity that you have. This goes into cricopharynx. From there, it continues as esophagus. We do have the diaphragm, which is going to be present here. It is going to pierce the diaphragm at the level of the T10. Then it goes into stomach and then into duodenum, right? So this is the objective that you have. Now, when a patient is going to consume an acid, so we're going to have two scenarios where you have the acid consumption and the alkali consumption, right? So we're comparing the two scenarios of the acid and the alkali consumption that are going to happen. Let's say in scenario number one, this is the patient has consumed acid. Number two, it is going to be alkali. Number two, it is going to have an ingestion of alkali. So when the patient is going to consume the acid, because it is going to be in low quantity as it goes, it will come in contact with the oral space. There will be oral injury. There will be some amount of the cricopharyngeal injury. Some amount it can go into trachea also. But if it gulps directly, it lands directly into the stomach, and as the most dependent area of the stomach is going to be the pyloric region, so it can be associated with the pylospasm. It is going to result in pylospasm. Alkali, on the other hand, when the patient is going to consume, as I told you, it is going to require longer duration of time, as well as it is going to cause a transmural damage. So when it goes and settles into the stomach, it is now going to cause an extensive injury in the stomach of liquefactive necrosis, as it is going to be in the most dependent area, right? So what is going to happen? The acid will have more of oro airway, I would say the disorder, the injuries that are going to happen. The alkali, on the other hand, as it goes down and then it is going to disrupt the entire component of the stomach, right? Let it be an acid or an alkali. What is your line of management? Or I could say, what is the protocol that we are going to follow? So when you look at the protocol for the management, when you look at the protocol for the management, the first thing, obviously, see, all these requires a very quick successive component, but it will go in a logical manner. I want to stabilize the patient. I will start the patient on IV fluids. Usually when you talk about nasogastric, when you talk about acid or alkali ingestion, you want to cleanse everything now. You want to, prevent it from collapsing. I know all that is there. You want to give a lavage or a wash. Agree. But before that, remember, never push a nasogastric tube blindly, because when you're trying to do that, it might cause more injury than benefit. So avoid blind nasogastric tube. That is your Ryle's tube insertion. So start the patient on IV fluids. Avoid blind nasogastric tube. अगर आप blindly nasogastric tube डालने की कोशिश करोगे, it might, क्योंकि already injury है और आपको extent of injury का पता नहीं है, आप क्या करोगे? While putting that, it will cause more injury or damage than the benefit itself. ठीक है? So start the patient on IV fluids. Avoid nasogastric tube putting blindly. Start the patient on prophylactic IV antibiotics. Start the patient on prophylactic IV antibiotics. IV antibiotics, and then plan for an upper GI endoscopy, that too in an emergency setting. Earlier the better. Now the protocol says within the 48 hours. If patient presents to you within the first 48 hours, start the patient or do an emergency upper GI endoscopy, right? Now, once you have done an upper GI endoscopy, you can now quantify the injury. So, based upon the endoscopy, we have the grading of the injury, and the injury grading is what we call it as the Zargars grading system. Okay? Again, important. So, let's try to understand what did the Zargar guy try to tell us. So, we have the Zargars classification. It's an endoscopic classification. It is an endoscopic classification. The Zargars classification is an endoscopic classification of the injury that is being created. That is both acid or the alkali injury. Both acid or the alkali injury. So we'll try to understand what it basically means. Okay. So according to Zargars injury, you have grade and the findings. So we have grade on one end and the upper GI endoscopic findings on the other end. ठीक है? So एक end पे grade है, दूसरे end पे findings है. Let's try to understand both of them. ठीक है? Now let's say a patient had come. अब पेशेंट बोल रहा है सर पता नहीं क्या पी लिया, कुछ तो हो रहा है सर, आई एम नॉट एबल टू अंडरस्टैंड, मुझे नहीं पता एसिड है अल्कली है. तो ठीक है, चलो देख लेते हैं कि क्या दिक्कत है. फॉर दैट द फर्स्ट थिंग दैट यू आर गोइंग टू डू इज टू पुट एन एंडोस्कोप. नाउ इफ इट इज नॉर्मल, मतलब भाई कुछ पंगा है ही नहीं, उसको लगा उसने पानी पिया और उसको लगा उसने कुछ और पी लिया, नहीं, ही हैज इंजेस्टेड वाटर and he is misinterpreting that he has taken something. Obviously the upper GI endoscopy will come as normal. So upper GI endoscopy being normal is what we call it as grade 0. Now in grade 1 it is now going to get a slightly trickier. So you will see presence of superficial edema. The presence of superficial edema, that is mucosal edema, can be noticed, or there will be presence of erythema. Either there is going to be edema or it is going to be an edema, or it is going to result in erythema. Erythema is nothing but redness, right? So when you put an endoscope, let's say I have a patient who had presented to me early, okay, let's say 1 hour within the ingestion. In those patients you will see the grade 1 injury, that is presence of superficial edema or the erythema per se. Then you have grade 2, it is split into grade 2A and grade 2B. So basically when you say grade 2, it has to form an ulcer. Now it could be either a mucosal or a submucosal ulcer. Based upon what is the depth of it, we will understand. So if you have the grade 2A, in the grade 2A there will be superficial mucosal there will be presence of superficial mucosal ulceration with edema or erythema. Okay, या तो edema या erythema होगा, but then you'll see all this is going to be contextually present. ठीक है, that is your grade 2A. Then you have grade 2B as well. Grade 2B is deep or circumferential, ulceration. So when I say deep or a circumferential ulceration, if you take this in the context of esophagus, right, and this is the mucosal wall, either the breach is going to be too extensive that it is going to go into deeper tissue, right, or you will see that it is involving the entire circumference. That means it is involving all round. Okay? Either it is going to go penetrate into deeper tissue or it is going to involve the entire extent, and that is what we call as deep or a circumferential ulceration. Now the grade 3 is going to be a transmural status. Grade 3 is what we call it as, one second guys, somebody is disturbing me. Okay, this is something which is not anticipated. I have a bee that is being all around in my studio. Okay, I know you should not kill, but give me a second. Okay, it's still being around. Okay, I think we have to bear with it. It is not in my capacity to do anything right now. Okay, we'll deal after the class. Hey, hi guys. Sorry I didn't look at the chat box. Yeah, I will continue with the light, guys. I know. I have a bee attack यार. I mean, be a little bit considerate. No, काट कोट लिया तो ठीक है. So grade 3 is going to be a transmural involvement. So when I say transmural involvement, we have 3A and 3B. ठीक है. 3A injury क्या है, 3B injury क्या है? If there is presence of a single side necrosis, we call it as focal necrosis. It is 3A. If there is an extensive necrosis, if there is an extensive necrosis, this is what we call it as 3B. An extensive necrosis is going to be 3B. Okay. So you should be able to know based upon an upper GI endoscopy that what are the findings, and based upon the findings you should know is it belonging to grade 0. So when I say grade 0, it is normal, nothing to worry. Grade 1 is an early finding that you have edema or erythema. Grade 2A is basically the injury associated. So when I say grade 2 per se, if I have to put grade 2 here, it is going to be mucosal. It is mucosal and submucosal injury. It is mucosal and the submucosal injury. Now in that you will have, if it is only associated with superficial mucosal ulceration, it is 2A. If it is deep or circumferential, that means deep all the way to submucosa. When I say deep, there is involvement of submucosa, then I would say it is going to be 2B. If it's a transmural involvement that is through and through, that is called as a grade 3 injury. In grade 3, 3A is focal necrosis, 3B is going to be extensive necrosis, but this is what your Zargars classification tell you all about. Okay? Now, when you have done the endoscopy, or let's say in any context, you will have two findings based upon the upper GI endoscopic findings. So in an upper GI endoscopic findings, either you will have a presentation of perforation, or there is surface injury. Either it will have be associated with a perforation, that means there's a hole that is created in the esophagus or in the stomach, or there could be a surface. Okay. Now if it is a surface injury, initially we will try with conservative line of management. We'll try with the conservative management and see whether it responds, and in future it is potentially developing into stricture. It is going to develop into stricture. Now stricture is usually seen in the esophagus. If it is an alkali injuries, it or in the acid one, it can also see in the pylorus of the stomach. It is the pylorus of stomach. So whenever a patient develops a stricture, either I can go ahead with dilatation to make it wider, or you have to go ahead with surgery. In surgery, if it is esophagus, then you have to go ahead with esophagectomy. Esophagectomy with stomach pull-throughs, or I can say stomach transposition. If it is stomach, then you have to do gastrectomy. If it is involvement of esophagus, you can get away with esophagectomy. If it is with the stomach, you have to remove the stomach. That is going to be gastrectomy. Okay, that is about the surface injury. If it is perforation, earlier what you have to do is you have to do a cervical esophagostomy so that you can drain it with feeding jejunostomy. With feeding jejunostomy, right? Now, without doing a feeding jejunostomy, you will not be able to feed this patient. So this has to be managed, and then you have to go ahead with definitive management thereafter. Okay. So if it's a perforation, do like you have to take the patient on an emergency basis, do a cervical esophagostomy, that is going to open the esophagus on the left side of the neck, and then do a feeding jejunostomy, manage the patient accordingly. This patient might require a total parenteral nutrition also. Here also patient might require a TPN. We have a whole discussion on a total parenteral nutrition, how to give, what to give, when not to give. All that will be covered in our subsequent classes. But this is based upon the upper GI endoscopic findings and its management. Is that clear, guys? Many a times now when you're going to write your exam questions, or let's say you're attending any competitive exams, majority of the times you will actually come across this. Okay? So that is going to be your Zargars classification, and that is based upon your upper GI endoscopy. That is going to be based upon your upper GI endoscopy. Yeah. So far, any questions, guys? Quick feedback. Anything that you want me to repeat? Any questions? Any doubt? Anything subsequent that you want me to give you an objective about? Quick feedback. Yeah. Great. Yeah. If you're thinking about if it is involving, like I said, cervical esophagostomy, if there is an esophageal injury, but if there is a gastric injury, you can do a gastrostomy. You can perform a gastrostomy with feeding jejunostomy. Remember, immediate reconstruction is not recommended. We usually wait for 6 months. So after 6 months, we do a definitive surgery. Then you can plan for a definitive surgery. Okay. So this is with respect to the caustic injuries about the acid and alkali. We should know what are the components. So this is the most important concept to be remembered whenever a patient has come with a corrosive injury. There's an accidental ingestion of both acid and alkali. How do they present? What are the basic implications? And then the management and the treatment protocols as well. Right. So that's it for today. Thank you so much for joining. We'll see you next week again on Monday, Tuesday, Wednesday with the BLS series. We are almost ended the esophagus. I think there's only esophageal cancer that is left. Probably 1 or 2 sessions for that, and we will be able to finish. All right. Until then, thank you so much. Good night. Take care. Bye. Have fun. Oh, wait. Where do you get these notes and any questions and any queries? You know where to get us, right? So any questions, any queries, write us on this, the Instagram as well as Telegram. It is called as the surgery guy. It is by my name, that is Dr. Sandeep Reddy. Any questions, any queries, reach us out here. It has got both the same. It is the Insta as well as your Telegram. Okay. So both channels you will have the access here. Okay, please explain with a case scenario. But I would so love to explain the case scenario, but the issue is the YouTube does not allow me to put out a content that might not be suitable for audience, because I know I'm a surgeon, I know you are a doctors, we understand each other's language, but the YouTube does not. Okay, so if I try to put any video which is having blood, necrosis and all, they ban our video. That's a problem. Now, in a case scenario, I can tell you, I had this one guy who was 18 years old, love failure. The girlfriend said no, as common story in India, it happens. That guy went, I mean, that two set of guys, one who would harm themselves and one who would harm the other person, but this guy was like quite good. So he decided to go close the door and drink Harpic, right? I know, like that's I think the most suicidable agent that is available. Went inside, gulped it, and after gulping, 15 minutes later, he goes and tells his parents that I've done something, and then the problem is the parents did got us. He came to us. It was, if you look at his Zargars, it was 3A, focal necrosis, but then it became extensive. We did a feeding jejunostomy for that patient, started the patient on TPN. but again quite difficult. You know, that's an 18-year-old kid, and there was a quite extensive damage in the stomach. There was a patchy esophageal involvement also. We know in future the patient will develop an esophageal stricture also. Problem is to counsel the patient, counsel the parents. See, there it was not only the battle of that kid who was 18 years old, but the entire family was suffering. And trust me, I mean, like, in that way, the parents are quite amazing, right? Not even a single time the father or the mother said, you know, why did he do that? The only thing that they were, probably in front of us at least, the only thing that they were concerned about is like, by hook or crook, I don't know what you do, get my son back on foot. That's the only indication or the, you know, intent that they had. We struggled hard. The patient did come us for follow-up after 6 months. We did a gastrectomy, we did a mobilization, reconstructed the conduit, but again, you know, the quality of life will hamper. Okay. So all these cases, no, they're like, for an undergraduate perspective, it is quite little that I can teach you, but from a clinical implication and practice, it is huge. There are a lot of things that you would take into consideration. See, in surgery, we say getting out an organ is quite simple. Okay, you went inside, you took something out, done. But the problem is you can never undo that. Things that you have removed are done. You cannot put it back. So when you join surgery residency, and if you get ever to work with me, my only advice to every single new resident or a new junior that joins in our team is to understand when not to operate, right? Forget about when to operate. Everybody knows when to operate because they're clear-cut guidelines. The thing is when not to operate, right? So a good surgeon is a surgeon who knows when to operate. A great surgeon is a surgeon who knows when not to operate. So you need to understand that what is your limitation as a surgeon? What are the consequences? As my father always used to say, that every time you do something, think about the power of consequence. If that thing or that outcome that you're gonna get, are you able to justify that? And if you are able to fight through that, then go ahead. But if you feel the consequence that is going to come out from a certain action is irreversible or beyond repair, it's better to avoid it, right? So in medicine, there's a very powerful quote: we don't teach you what to do, we teach you what not to do. If you're clear about what not to do, everything else that you do is acceptable, and that is what we call it as practice. We don't say perfection, we say medicine is a practice. You can never perfect it because there's always something better and there's always something hidden, right? So with that message, thank you so much for joining today. We'll resume back next week. Thank you. Goodbye. Have fun.